This is a lecture on substance-related and addictive disorders. Substance-related and addictive disorders is not a new problem. The use of these mind-altering substances goes back to antiquity. They've been around for many years and have caused impaired quality of life for equal amounts of time. Substance abuse, by definition, is the use of a substance that occurs outside of medical necessity. The use of the substance occurs outside of social acceptance and results in adverse effects to the abuser or to others. Substance addiction, some definitions: tolerance occurs when the patient has to take more of the drug to stay normal or to prevent withdrawal. They lose control over the substance. Addiction can be fatal. Compulsive behaviors centered on drug use and drug-seeking behavior. Behaviors are motivated by drug cravings, and it is a chronic relapsing brain disorder. As far as diagnosis, you should remember the 4 C's, including compulsive behavior. So the patient is compelled or has a compulsion to find and take their particular substance. They also have cravings for the substance. It is a chronic relapsing brain disorder, and the patient also experiences cognitive impairment. On page 363, you can see that the DSM-5 uses the term substance use disorder, which covers 10 classes of substances, which are listed here: alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotic, and other or unknown substances. Prevalence and comorbidity. Alcohol use disorder is the most common substance use problem in the United States. Marijuana is the most commonly used illicit drug in the United States, with the exception of Washington and Colorado, who have legalized it for recreational use. The use of club drugs is increasing, including ketamine, ecstasy, LSD, and methamphetamine. There is also prescription drug abuse, especially narcotics, prescription painkillers. It's considered prescription drug abuse when they are used for non-medical reasons. The use of anabolic or androgenic steroids or testosterone. And then, of course, the use of nicotine. Substance use disorder or substance abuse disorder often co-occurs with depression, schizophrenia, and anxiety. Signs of substance abuse. This is in the many tables throughout the book. The tables are specific to the particular drug. So, for example, table 19-9 talks about the club drugs. 1910 talks about the hallucinogens. 1911 talks about dissociative drugs. 1912 talks about inhalants. And then 1930 is a screening instrument for the use of alcohol. It's important for you to review those throughout the book. Some others that I'm just seeing here, as well as table 19-7 on 376 and 19-8 on 377. Each one of those tables talks about the specific drug, what effects intoxication has, what the overdose effects are, and then what the withdrawal effects are. So, for example, for opiates, there are many opiates that are listed here on table 19-7 on page 376. But we'll use oxycodone as an example. If a patient is abusing oxycodone, intoxication, you'll see constricted pupils or pinpoint pupils, slowed respirations, drowsiness, decreased blood pressure, slurred speech, psychomotor retardation. Initially, they will experience euphoria, but this is followed by dysphoria and impairment of attention. They also have impaired judgment and impaired memory. Excuse me. Overdosage, you'll see a triad of symptoms, which is coma, respiratory depression, and pinpoint pupils. So those three are the triad of morphine overdose, opiate overdosage. They can also experience cardiac arrest and death, shock, and convulsions. The treatment for opioid overdose is Narcan, which quickly reverses central nervous system depression. Effects of withdrawal include yawning, insomnia, irritability, runny nose, panic, diaphoresis, cramps, nausea and vomiting, muscle aches, chills, fever, tearing, and diarrhea. Withdrawal treatment can include methadone. Methadone is often used to treat heroin addiction. Methadone is substituting one addiction for another because methadone is considered safer because it doesn't require the use of IVs. And then methadone is also a regulated drug by the FDA, so it allows for gradual tapering. There's combination drugs, including Suboxone, Vivitrol, and clonidine naltrexone, which may be used to treat withdrawal. Compulsive addictive disorders. Include those disorders where the patient doesn't necessarily abuse a substance, but they still have an addiction to a non-substance behavior, such as gambling, shopping, internet use, and compulsive sexual behaviors. The neurobiology of addiction includes the neurotransmitter dopamine, which regulates pleasure and pain and plays a major role in all addictions. The drugs we've discussed that are abused affect the limbic system or the reward system. So the first time these patients use these drugs, they experience a large release of dopamine and they experience intense pleasure. The neurons are unable to regulate that dopamine, and the dopamine is unable to stimulate the reward center. So more of the drug is used to increase the dopamine levels, and then that begins the cycle of tolerance, which leads to dependence and ultimately addiction. In terms of assessment, it's important to clarify presenting signs and assess for withdrawal as well as overdose. Assess for self-harm potential, evaluate their physiologic response, explore the individual's interest in taking action, so are they motivated to change, and assess their knowledge of community resources. Substance abusers will use defense mechanisms, including denial, minimizing rationalization. A lot of times they will use these defense mechanisms and it's difficult to get a straight answer out of them, how much they actually do use and what all they actually use. The screening instrument on page 383 is called the audit test, which is an evidence-based tool to help assess the patient's alcohol use. So the score of 8 or more for men or 4 or more for women or adolescents is considered a positive screen. If they're positive, then they need a referral for psychiatry or evaluation for substance use disorder. remember that if the patient is going through acute withdrawal, they may require inpatient medical hospitalization until the acute phase passes. Another screening tool is Cage Aid, which is an alcohol screening tool. So the C stands for cutting down. Have you ever felt like you need to cut down? A, have people annoyed you by criticizing your drinking? G, have you ever felt bad or guilty? The G is for guilty about your drinking or drug use. And then E, have you ever had a drink or used drugs first thing in the morning? In other words, it's called an eye opener to steady your nerves or get rid of a hangover. And then A is adapted to include drugs, which just means that the tool itself has been adapted to use drugs or okay. Assessment guidelines for the chemically impaired. So you have a patient who is currently actively impaired. You need to assess them for withdrawal syndrome. Assess for an overdose that warrants medical attention. So that would be an overdose that is potentially life-threatening. So for example, if they have severe respiratory depression, then that would warrant medical attention. Also, if they have suicidal thoughts or other self-destructive behaviors, that may warrant one-on-one suicide precautions. Knowledge of the patient and family of community resources. So ask them if they're aware of the resources that are out there to help them. Also look for physical complications related to drug abuse. So for example, at the hospital we oftentimes get heroin abusers who have skin infections from their injection sites. So that would be one physical complication. And then explore the patient's interest in doing something about the drug or alcohol problem. And oftentimes they will be upfront and honest with you and tell you that they just don't want to quit. Or else, more often than not, they very sincerely want to quit, but remember that it is a relapsing disease, and they do experience relapses, which is challenging for the patients and families. So, alcohol withdrawal, acute alcohol withdrawal versus alcohol delirium. We talked about delirium a little bit in the chapter over neurocognitive disorders. This is delirium specifically related to alcohol withdrawal. Alcohol withdrawal in a chronic alcohol abuser may be seen within a few hours of the last drink. And then it peaks within 24 to 48. It rapidly and dramatically disappears unless it progresses to delirium. The patient may complain of irritability or feel like they're shaky inside. They may have grand mal seizures in 7 to 48 hours cessation or after their last drink, and then illusions are also common. Withdrawal delirium, on the other hand, is a medical emergency and can result in possible death. Alcohol delirium peaks 2 to 3 days after cessation or alcohol reduction, and it includes autonomic hyperactivity. These patients develop sensorial and perceptual disturbances. They have fluctuating loss of consciousness. They may have paranoid delusions, agitated behaviors, and an increased body temperature. Nursing diagnoses for the patient with substance abuse disorder. Impaired nutrition. Oftentimes these patients will more readily give up food than they will their chosen substance. So they'll forego eating or drinking in favor of alcohol or drugs. Ineffective airway clearance, ineffective breathing pattern, ineffective health maintenance, disturbed thought processes, disturbed sleep patterns, hopelessness, risk for suicide, and risk for other directed violence. Pharmacologic interventions for the treatment of alcoholism. We talked about Revia or naltrexone, which reduces or eliminates alcohol cravings. Camprol helps patient abstain from alcohol. Topamax works to decrease alcohol cravings. And then Antabuse causes unpleasant physical effects. So if there is an alcohol drug interaction there that makes the patient sick. So that makes it's an alcohol use deterrent. Types of treatment for addiction. Conventional treatment includes psychotherapy or talk therapy, group therapy, cognitive behavioral therapy, motivational incentives, and motivational interviews. Recovery models, which are more popular in this era of psychiatry, include the 12-step program, AA, Alcoholics Anonymous, which is the prototype for all 12-step models, and that were subsequently developed for many types of addiction. These programs offer behavioral, cognitive, and dynamic structure. There are 3 basic concepts in all of these, which includes Alcoholics Anonymous, Al-Anon, and Alateen. Number 1, they have to the person with the addiction is powerless against their addiction and their lives are unmanageable. Number 2, although individuals with addictive disorders are not responsible for their disease, they are responsible for their recovery. And number 3, individuals can no longer blame people, places, or things for their addiction. So oftentimes you'll hear patients say that they're working the steps, and that's a program that has been around for many years. And it continues to stay around and be an effective program. So AA is Alcoholics Anonymous. Al-Anon is for the family members of abusers. There's Narc-Anon, Narcotics Anonymous, Overeaters Anonymous, Alateen. There are several 12-step programs that are out there, and they're all based on that same basic 12-step program. Another one is Self-Management and Recovery Training, or SMART, which is based on cognitive behavioral therapy, which helps the patient to enhance and maintain their motivation to abstain, helps them to cope with urges. It also teaches them problem solving and life balance. There are many recovery programs that are out there, including residential intensive outpatient. Actually, that's supposed to be residential. And then the next one is intensive outpatient. And then outpatient drug-free and employee assistance. Many places now have employee assistance programs that are available to help provide some of the mental health services, particularly substance abuse. So that might be something that we need to help our patients look into. So the recovery paradigm emerges from hope. It is person-driven. So in other words, it's driven by the individual themselves. It has many pathways. Is holistic. The person needs to be supported by their peers and allies. And it also provides support through relationships and social networks. It's culturally based treatment. And it's supported by addressing trauma, whether it's physical, spiritual, or emotional trauma. And it involves the individual, community, and respect. This is the same recovery paradigm that we talked about early in the semester, like in the first chapter or 2. So, we already talked about Alcoholics Anonymous a little bit. Spirituality is an important thing in Alcoholics Anonymous. And they often will call it a higher power, so that it's not religiously based, and that higher power is whatever it is to that individual, whatever is in control when they are not. That becomes their higher power. For Christians, it would be God or Jesus, whereas for other people, it may be something else. Spiritual practices in recovery are associated with better outcomes. So it's important to foster their spirituality. Even if they're not religious people, we can still provide spiritual care to them. Higher spiritual levels often correlate with a sense of purpose, gratitude, and forgiveness, which is all the way around more mentally healthy for everyone, whether they have a substance abuse disorder or not. So the goal then is to prevent relapse. basics early in recovery. It's important to keep the program simple. Review the instructions with the health team members. Write down important information and telephone numbers. So what is the patient going to do? They need to have a program. What are they going to do when they feel like they need to use? And relapse prevention is included in your book starting on page 387. Basically, the focus of relapse prevention is to give the patient a plan of action for their trigger situation. So whatever triggers them to use, they need to learn new ways to deal with those situations. Box 19-6 on page 387 has some relapse prevention strategies. Skills, cognitive behavioral therapy can help the patient improve their coping skills. Maybe they can learn new coping skills or learn which ones are bad so that when they start to use those coping skills, such as defensiveness or rationalization or something like that, they can catch it and put into place a new coping skill. There are also relapse prevention groups excuse me, that provide a social support system as well. And then the relapse is very important to enhance the person's personal insight. And that can be through group, individual, or family therapy. And it helps them to analyze their substance abuse and the motives behind it and what alternatives they have for instead of using. So that's the end of this lecture. If you have any questions, be sure and let me know.